All right. We are talking about cystitis today. And there's a lot of different chapters. There's sort of disorders of micturition, cystitis, and also urethral and ureteral diseases. But I feel like we talked a lot about ureteral diseases in particular last time we met. And I just wanted to kind of cover everything together because really the presenting signs of all these lower urinary tract things are the same. So I thought we'd use kind of a bit of a case-based approach, but before we dive into that, I would like to just talk a little bit about the innervation of the bladder, what's responsible for what, and how bladders dysfunction. So who can tell me which nerve is responsible for contraction of the bladder detrusor muscle?
That's the parasympathetic, which is... I made the students learn this, and of course I've forgotten it.
Instantly.
I'll have a guess at the pudendal.
It's not pudendal. Pudendal's the somatic, the voluntary relaxation of the urethra.
Because it's a parasympathetic function, isn't it?
It's parasympathetic, exactly, yeah. And the nerve is the pelvic nerve. Does anyone know where that arises? Which spinal cord segment?
S1 to S3.
Very good. So fast. And what about, so that's contraction of the detrusor. So if you've got a lower motor neuron bladder and S1 to S3 is dysfunctioning, so you've got, say, bulging disc on lumbosacral spine or something like that, how will that present to you clinically?
This is you get no contraction of the bladder, and I think the sphincter is open, where it can't contract itself. So you get kind of this leaking but not emptying of the bladder.
Good, exactly. Yeah. So the bladder is large and flaccid on palpation. The pudendal nerve that Jeff mentioned before, which is responsible for the conscious urination, so conscious contraction, detrusor contraction and relaxation of the urethra. What segment does that arise from? Does anyone remember?
Is it the same?
Yeah, it's S1, S2. Yeah, so it's slightly more cranial, but they both sort of start at S1 and the pelvic can go right back to S3. So if we've got a lower motor neuron bladder, we've got loss of urethral contraction and loss of detrusor contraction. So we've just got this relaxed bladder. Big flaccid bladder, overflowing incontinence with lower motor neuron presentation.
Which is easy to express as well.
Easy to express, exactly, because that urethra is just flaccid. What about if we've got what's responsible for bladder relaxation and filling? And so what relaxes the bladder and constricts the urethral neck, the bladder neck?
That's sympathetic system, I think, isn't it?
Exactly, yeah, exactly.
So that's probably the hypogastric nerve.
Hypogastric, exactly. Where does that come out of the spinal cord?
That's much higher, around about L4.
Yeah, good.
Or so.
Yeah, exactly. It's L1 to L4.
Oh, good. I got one of them right.
Yeah. So we've got pelvic is the parasympathetic. And we know that when the animals aren't going to need to wee when they're running away from a tiger, it's when they're relaxed, so parasympathetic. Whereas when the sympathetic nervous system is activated, we've got retention of urine, we've got urethral contraction and relaxation of the bladder to be able to hold more urine. So what does an upper motor neuron bladder look like?
Hard and turgid, can't express it very easily.
Yeah, exactly. So increased tone in the urethra, and often it's a sort of firm, quite a firm bladder.
And
Good.
difficult to express.
Difficult to express, exactly. So when I think about urinary disorders, I like to think of them as disorders of storage or disorders of emptying. And that kind of just helps me sort of categorize things in my head. So if we talk about incontinence, how are we going to do this? First, I want to talk about what local immune system is present in the bladder to try and prevent cystitis.
Well, it's the washing out effect is one of them.
Good. Yeah. In those dogs we were talking about that have a large flaccid bladder and a wide open urethra, we know that they're more prone to infections. So micturition is really important, and the important components of it that it has to be regular and it has to be complete. If you've got retention in the bladder, there's much more likelihood of having urinary tract infections develop. So good micturition, flushing out. What else is in there that prevents infection?
It's the lining of the bladder, isn't it? What do they call it? I can't remember the name of it. But it's the one that they theorised was going to be assisted with Cartridge-Fin and the like.
Yeah.
And I know I've used that successfully, but I see Ettinger, the article on it, is not so enthusiastic.
Yeah, it jury's out a little bit. Can do no harm though. It's pretty safe supplement. So Cartridge-Fin, what's the thing that increases?
Glucosaminoxidase.
Yes, good, exactly. So the glycosaminoglycans that line the bladder help to prevent bacterial binding and seal the bladder, the cell-cell junctions in the bladder. The other thing with the mucosa is that it exfoliates. So there's sort of regular turnover of cells. So if we do sort of end up with an intracellular infection, those cells are going to slough eventually. Or if there's bacteria bound to the surface, it's going to come off eventually. What about physical factors? So why are females more prone to urinary tract infections than males?
Length of the urinary tract.
Yeah. Of which part of the urinary tract?
Urethra.
So, you've got to say that word. Excellent.
Boys have two sphincters. They have a lower urinary sphincter. Is that right?
I don't know, actually. I
think
it's
two. Maybe it's just the distance. I can't remember.
Yeah. It's distance, but it's also what's the most common bacteria causing a UTI?
Like an E. coli, like a fecal.
Yeah, exactly.
Fecal.
I'm not sure that's the word.
I don't think I'll make it.
Good morning.
Coliform.
Coliform. That's the one. Much more familiar.
Yeah.
So we've got the feciforms coming from the colon. So obviously the tip of the urethra in a male is really far from the anus. So there's much less likelihood of fecal contamination of the distal urethra in a male dog or cat. Less so cat, but definitely dog. So those physical properties of urethral length and higher up, what stops pyelonephritis from developing, or what physical properties help protect the kidneys from ascending infection from the bladder?
The valves, where the ureters connect to the bladder, it's a one-way system.
What's the valve called?
I was hoping someone else knew. I don't know.
Is it vesiculoureteral?
Yeah, the
other way around.
Vesicular, yeah, exactly. But I'd give you full marks for that. You said the combination of words that needed to be said.
Thank you.
Very good. So does everybody remember that anatomy that we talked about? It was probably 6 weeks ago or so. The ureters come down to the bladder. So if we're looking at a lateral, kidneys up here, ureter comes down from here and it gets down to the pelvis and it does a complete U-turn and plugs into the bladder that way. So if you can imagine the bladder filling, as pressure inside the bladder increases, that ureter kinks and the pressure can't result in backwash of urine up into the kidney. So there's kind of this protective mechanism. It's not actually a valve. There's no sphincter or anything there, but it is this sort of, as pressure increases, there's less likelihood of renal reflux. What about the actual properties of urine itself? How do they protect against an infection?
pH.
pH, good. Yeah. Anything else? Urea's actually got antibacterial properties and it's present in very high concentrations in urine.
So I guess urine concentration itself.
Good, exactly. And the important thing about that is that when we're then considering cystitis and dogs that have high risk factors for cystitis and subclinical bacteria, those dogs that have low USG or low osmolality and concentration of the urine will have less of that innate protection against bacterial infection. So any disease that causes low USG will result in a predisposition to cystitis. I shouldn't say cystitis, bacteria. I'm going to try and be careful about my nomenclature because it's changing all the time. So I don't know how much reading you guys did for this session, but there's been quite a few consensus statements from the different kind of ECVIM, ACVIM, and then another one since, which I didn't write down the name of, but that's the one that I sort of used for today. And the naming of the different types of bacterial infections and subclinical bacteria and things have changed a bit. So I'm going to try and be careful about how I say things. Okay, so if we want to talk about, do you guys want to focus on cystitis or should we do some incontinence stuff as well?
Both would be a good idea, if possible.
So, yeah, okay, let's see how much we can get through. So we've got a 2-year-old female D-sex dog who was acquired as a D-sex female at 4 months of age, who's presented for, owner just says incontinence. She's weeing in the house. What questions do you want to ask to help you clarify your differential list?
I'd want to know if she actively urinating or is it leaking?
Mm-hmm.
And kind of when during the day it's happening to try and help clarify that. So is it more nocturia or during the day when she's lying around or yeah, those questions?
Yeah. I think everybody's done this clinically, so I won't torture you by making you do this. But the owner says, oh, there's just tiny little puddles next to the back door. How does that change your approach to incontinence in this dog?
I mean, it sounds like the dog's trying to get outside to wee, but it can't. So I guess I'd want to clarify if the door's open or not.
That's
Yeah,
right.
Does it lie next to the door and sleep there? Or?
Yeah, that's actually a really good question. Yeah. So I guess that this dog is, say the door is closed and the dog's leaving tiny puddles, just trying to get out and hasn't quite made it. I think we'd probably say there's an increased sense of urgency to urinate. What differentials do we have for that?
Well, urinary tract infection is one of them.
It's pretty much the main one. If it's sudden onset, young dog, D-sex female. There's, particularly in humans, the most common cause of incontinence in humans is detrusor hyperreflexia. And there's certainly dogs that have less ability to hold on. So there's probably a variant of that. But obviously dogs can't report a sense of urgency to us. So we probably underdiagnosed sterile increased detrusor activity. as a cause of that urgency, but that's very unlikely to be acute or sudden in onset. It's going to be lifelong tendency. So very unlikely to present in this way.
There's another condition to do with the spying, and I've forgotten, to do with the vagina, and I've just forgotten what it's called now. You can diagnose it with contrast radiography, and it's colposuspension is the way that it's treated.
Okay. So let's change the history slightly and say that this patient presents with just a wet bed in the morning, and she smells like wee a little bit, but the owner thinks she goes out and wees normally during the day, and squats and postures normally, normal stream, normal size, no hematuria. So that sort of more history of true incontinence. What differentials do we have on the list for that?
USMI would be a big one. Just give
Can you spell it out for us?
Urethral sphincter mechanism incontinence.
Yeah.
So the inability for the urethra's sphincter to close appropriately, so they just leak.
Yeah.
And I think it's mostly hormone related, which is why we see it with D-sex females.
Exactly right. Yep. So urethral sphincter mechanism, I think it's actually incompetence rather than incontinence. Yeah. So that's the sphincter mechanism that's incompetent, but it causes incontinence, obviously. There's a kind of a whole different spectrum of presentations, but the classic is a dog that was D-sexed before 6 months of age, because the exposure to estrogen during that kind of puberty phase of development in a dog is actually dictates how many estrogen receptors are in the urethra and vagina, and will dictate urethral tone. So D-sexed female dogs will have decreased urethral tone when measured, if they're D-sexed sort of younger in age. There's a couple of papers that were quite small in size that said, no, there's no relation to early age of D-sexing and incontinence. And pretty much every single vet in the world was like, yes, there is. And then more papers have come out since which supported that is the case. D-sexing before 6 months of age is a predisposing factor. Another thing that I talk about at, there's groups doing the, oh my gosh, what's the word? I got a new puppy and I'm not sleeping very well.
A new puppy?
So exciting.
You can't just say that and you don't have said puppy.
I'll bring her out at the end as a reward for everybody.
Okay. What kind of show is this?
She's about this big and she's anyway, the word I'm looking for has to do with endoscopy that is interventional endoscopy is the word I'm looking for. So there's a group in New York which have been really sort of progressing what we can do endoscopically, or like minimally invasive procedures. So they do all their ectopic ureter surgeries and stuff with laser via cystoscopy and blah, blah, blah. Anyway, they report on urethral sphincter mechanism incompetence being a couple of different forms. And one is this short, wide urethra, where the bladder is quite pelvic, the urethra is quite short, and it's just really wide. And that's not like when they do cystoscopy on those dogs, they're sort of going, oh my gosh, I'm in a gaping cavern and then I'm in the bladder, rather than in a tiny little tube, which a normal urethra would look like. And they're the ones, Jeff, that traditionally we used to do colposuspension. So the ones where the bladder was pelvic and we'd pull the ligaments down to hold the bladder in the abdomen. And that they've actually moved away from doing that because the response to therapy has been not as good as we get with medical therapies. I think since propylene was released, the treatment of choice now is medical. And then again, this group that's doing the kind of interventional stuff have developed an artificial sphincter that you can put around a urethra in this case. So if medical management fails, you can put in a sphincter with a little port under the skin and you gradually increase the amount of pressure that sphincter has in it by increasing the volume in it. Has everybody or anybody had any experience with them or seen them? It's pretty cool. They're called hydraulic occluders, and it's literally just a little fluid-filled donut that's placed around the urethra surgically, but like little surgery, like it's like a spay wound. And you just slip it in and tie it up. I think it's more complicated than that, but Jen's done it. She's laughing. It's not like that. And then they've got this little port that, you can, if they're still incontinent, because you don't even fill it up after surgery. If they're still incontinent, you put more and more fluid in until they're continent. So essentially if we think about the kind of physics of urination, it's a balance between pressure in the bladder and pressure in the urethra. So every sphincter has its limit. So if you generate enough pressure in the bladder, the urethra will eventually leak, but the pressure in the bladder required to cause leakage will be variable between dogs. Does that make sense? And then if you vary the pressure in the bladder, so for example, if we've got a hyperreflexive detrusor muscle or cystitis causing increased contraction in the bladder, you might get some incontinence if that urethra is not that strong. Is everybody following? Does that make sense? So sometimes we do get a little bit of overlap between the presentations and the history that owner gives us. It might be true incontinence when they've got cystitis because of that increased bladder tone. Okay, so urethral sphincter mechanism incompetence. The other differential we should have on our list for this leaking dog at night is a lower motor neuron bladder. There's something neurological going on. And that's pretty much it. But, obviously, if it's onset as an adult, very unlikely to be. What are the other differentials for incontinence? You say this was a 4-month-old dog who's always been incontinent.
The ectopic ureter. That's
the main one. Actually, there's one more we should mention, which usually is present from a young age as well. And that's juvenile vulva. Sometimes if the vulva is quite recessed, urine can pool in there. And then when they lie down and their kind of muscles relax or they put pressure on their vulva lying down, it kind of just overflows out. And it's not actually that there's a problem in the urinary tract, it's just the vulval malformation. And so that's a consideration potentially as well.
And when is the short wide urethra just anatomical, or is that hormone related that it develops that way?
It's anatomical.
Right. So if works rather than diethylstilbestrol, say.
Yeah. Sorry, say the question again.
Is that why propylene would be effective for that rather than stilbestrol? I'd probably use both. I usually use propylene as a first line and add stilbestrol as a second line if I'm not getting control with propylene. The reason is that they've still got estrogen receptors in that urethra, and particularly if they're desexed at an appropriate age, they've got lots of estrogen receptors. And if we can activate them and increase tone in that short urethra, we're still going to improve that balance of pressure in the bladder and pressure in the urethra. So I don't think it's definitely not contraindicated, but it's the hormonal ones don't have as many estrogen receptors, so they're actually still worth a try. Cool, thanks.
Yeah, no worries. Okay. What about if we have a 13-year-old cat who has all of a sudden started urinating outside of the litter tray and it's got a little bit of blood in it? It's a male cat. What's on our differential list for this old cat? It's never had these symptoms before.
UTI.
UTI, good. Yeah.
Neoplasm, you should have it on your list.
Mm-hmm.
Less likely to be fluted or just crystals.
Why?
If it's never had a previous episode.
Good, excellent. Yeah. So who was taught at uni that
In cats, it's virtually never an infection. It's almost always sterile cystitis. Me too. Yeah. So incidence in over 10-year-old cats, it's at least 50% likely to be an infection. So definitely worth having UTI on the list. I'm very glad you said that. Even in male cats. Good. So we've got idiopathic cystitis, UTI, neoplasia on our list so far. What else?
Urolith.
Yep, good.
Kidney disease with secondary UTI.
Yeah, for sure. And with the blood in it, it's not going to be behavioural, but if there was no blood, I'd probably put behavioural on the list as well. And the only other one is trauma, which would be bad luck. And usually there's a history there. Okay, so how are we going to approach this case? What tests are we going to do?
UA and culture analysis.
Yep, good. And your urinalysis shows that it's sterile inflammation and culture is negative. And on cytology of the sediment, you see a whole heap of struvite crystals. What do you do next?
Ultrasound the bladder. Just because it's crystals, you can't really equate that there will be cystolith.
Yeah, exactly. Yeah. So crystals are really common in urine. So and not necessarily pathologic. So if we see crystals in the absence of urolithiasis, then we wouldn't start sort of changing diet or anything necessarily. And it's not a risk factor for development of obstruction necessarily either. But it is something to then, if you've seen those crystals, it is worth ruling out a struvite infection. A struvite urolith or an infection, I think. But yeah, our culture was negative. We've done our ultrasound and there was sediment in the urinary bladder and a little bit of hyperechoic fat at the urinary bladder neck, surrounding the urinary bladder neck, so evidence of active inflammation surrounding the urinary tract. And the bloods were all normal that we did when we were doing our membership exam and wrote down all our tests that you can possibly do. So what diagnoses are we left with from our differential list?
Idiopathic cystitis.
Pretty much, yeah. What do we know what causes idiopathic cystitis?
Isn't it multifactorial? It's not a one.
Yeah, absolutely. Yeah. So there's absolutely no right answer. And also this is not really examinable because you couldn't do an answer key with like all of the different factors in there. I think it's interesting because I'm a medicine specialist, if anybody wants to go into it a little bit.
Yeah.
A little bit.
So I won't go too deep. What time are we? 8:30. Okay. So these cats are really interesting because they've often had some trauma in their first 8 weeks of life. So much higher incidence in orphan cats or cats that have had accidents or injury in their first 8 weeks of life, or illness actually in the first 8 weeks of life. So looking at their kind of how their nervous systems have developed. These cats have smaller adrenal cortices than cats that don't develop idiopathic cystitis. They've got decreased cortisol levels, but increased ACTH levels. So they're trying to produce more cortisol, but they've got a relative kind of almost adrenal insufficiency because their adrenals just aren't capable of producing as much cortisol. What else have they got? They've got their local kind of ACH, acetylcholine signaling is different from other cats that never develop idiopathic cystitis. And they've got
because of that, they've got excitable bladder cells, so more local acetylcholine signaling at the level of the bladder epithelium. And their bladder cells are therefore more excitable, which is sort of parallels with that human detrusor hyperreflexia. They've got decreased glycosaminoglycans in their bladder, in their mucosa, so decreased protection against injury. They've got increased urethral tone, so excitability in the urethra, than cats that haven't developed idiopathic cystitis. And they've got more arousal and startle responses than other cats. So they're the stressy cats. So what are some of the risk factors for development of idiopathic cystitis?
Recent stresses, early life stresses.
Yeah, exactly. I just find it interesting that they've got decreased ability to cope with stress from a kind of endocrine level, and that this kind of association with stress-induced cystitis, well, stress induction of the disease process. What are the most common stresses that we see?
The cat.
Another cat, exactly. Multi-cat households, much more higher incidence.
Changes in the environment, so like visitors and number of litter trays, that kind of thing.
Yeah. So I think environmental, cats that are indoor and using litter trays are overrepresented, and changes in location of litter trays and number of litter trays, potential triggers. And when you sort of meant changes changes in the environment, moving house is a huge trigger. So that's one that to always just kind of quiz about. What about, or say again?
Going to the cattery, like if they've gone to.
Sure. Yeah, cats don't like to move. What about physical risk factors? What body condition score are these cats normally?
Obese.
Yeah. What about their activity levels?
Not very active.
Not very active. They're always the slugs, aren't they? And what about diet?
Dry food more.
Good. Yeah. Exactly. Has anyone ever heard of Pandora syndrome? No? It's essentially a lot of these cats have comorbidities, so they might have respiratory difficulties, cardiovascular difficulties, derm presentations, or particularly GI stuff. Like they're much more likely to be chronic vomiters than other cats. And there's a group in the US that are kind of nephrologists and urologists of the veterinary world. Tony Buffington, who wrote the chapter on this in Edinger, has published so widely on this, but they've kind of coined this Pandora syndrome, which is just almost like this kind of inability to cope with stress manifesting as multi-organ dysfunction or multi-systemic dysfunction. And he's documented loads of cats that have got these kind of comorbidities, and by doing that multimodal environmental what is it called? Enrichment. Yes, thank you. It fixes all of the problems, not just the urinary tract problems. So these other problems might be related. Interesting concept, but you know, when you get those cats that just ain't doing right and it's after a stressful event, it's potentially something that we can get the owners to buy into. How do we manage this apart from the environmental? Does anyone have a good resource for the environmental enrichment? I wish I'd written it down now. You have to find it yourself.
The only things I know about are laser pointers, and also there are companies that will build sort of cat cages, if you like, out into the backyard, just designed to fit your particular backyard. And they've got all sorts of things in there to keep the cat interested.
Yeah. So I know JFMS, the Journal of Feline Medicine and Surgery, have done a review of this in 2014, and they've got really good, like, which environmental modifications work, which ones don't. But there's another one. What's the cat? Who oversees the cat friendly practice accreditation? IFSM. Thank you. That's what I'm after. They've got a really good handout that's free online that is like a survey that the clients can fill in, and like they draw where the litter trays are in their house and where the couches are and where the cat's beds are and stuff like that. And it can really help to understand how the cat's living at home and make the modifications required. ISFM. Thank you. What about in the acute presentation of a cat with cystitis but is not blocked? I don't really want to talk about blocked. We all know how to treat that.
Some pain relief.
Mm-hmm. Yeah, good. Which one?
I normally go with buprenorphine.
Mm-hmm. Good.
I've seen people do non-steroidals as well, but I think when they're unwell, I feel more comfortable with you.
Good. So there's been a few reviews on use of non-steroidals or prednisolone actually, or dexamethasone, so steroidal anti-inflammatories, and neither of them altered outcome or reobstruction rate. So the use of anti-inflammatories of either seems to be probably risk with no benefit. But certainly buprenorphine is recommended. What about long-term management if environmental enrichment is unsuccessful?
Moist diet.
Good, yeah. Increased water intake. Yeah. Absolutely.
Interestingly, that chapter in Ettinger wasn't strong on that, but
I know they weren't, were they?
Yeah, but I used to enjoy telling the students that the chemical that was most successful in managing this is dihydrogen monoxide, and it took them a long time to figure out what that was.
I think in the chapter they mention the veterinary formulated diets were like slightly better or something than a normal commercial diet as well.
Yeah, outcomes, what, as in reobstruction wise? Yeah.
But it's always amazed me just adding water to the food. They'll always drink it. And being fussy eaters, I didn't think it would work, but every time I've tried it, it's worked.
I struggled to get my own cat. One tutorial. I discovered that my cat was blocked when I woke up in the morning, and I raced the cat up to work, dumped it on the table, and said to Helen Farris, "Help me, unblock my cat." And then I raced into the medicine office and ran the tutorial. I listened and raced my cat. They'd fixed my cat for me. But I actually couldn't get my cat to eat dry food with water on it, and I eventually got him on a wet food diet, and he's done quite well on that. What about if you would do, so say our cat that we're talking about was blocked and we unblock it, we do the kind of physical unblocking. I don't want to talk about that. What about kind of medical management? We've got buprenorphine. Anything else?
I would, yeah.
I traditionally use prazosin.
Amsulosine.
Yeah, it's hard to get. You'd have to get it compounded, so it's not, because the tablet sizes are too big. So it's hard to use in an acute setting.
Also Cystiphan.
What was that drug again? I didn't catch the name.
Tamsulosin. It's a similar class to prazosin, or prazosin, however you say it. Essentially urethral relaxant. Has anybody seen the recent literature on use of urethral relaxants in FRC or urethral obstruction? It's going out of favour.
Prazosin is.
Yeah. We've done a few. Oh, go again, Josh.
Oh, sorry. I was saying, I remember we used to use it. I used to use it a lot, and then add in other kind of skeletal relaxants as well, like dantrolene as well.
So we used to use, in particular at North Shore, I think you probably were influenced by that as well. We'd use prazosin or phenoxybenzamine as a urethral relaxant,
and then we'd hit them with dantrolene is botanicol, isn't it?
No,
No, that was
botanical's different.
Yeah, so we'd hit them with botanicol a half an hour after the oxybenzamine to sort of relax the urethra and then help contract the bladder, because often they've got atony after they've obstructed. So that's definitely out of favor, the use of botanical, obviously, when they're obstructed. Increasing bladder tone is dangerous. But the use of prazosin, there's now been some really reasonable size studies that show that there's no decrease in reobstruction rate either in hospital or in the 30 days afterwards with the use of prazosin, which suggests it's not really changing outcome. And there's some soft evidence that maybe the outcome was slightly worse in the cats that were given prazosin, but there wasn't enough cats in the study to really conclude that. I'm always suspicious of veterinary studies just because the numbers are so low relative to the tens of thousands they use in the human studies. And prazosin makes good clinical sense. We've done it for a long time, but there's actually no evidence to use it now. And maybe some evidence that we shouldn't. So I would move away from that. Some interesting evidence on cannabis oil coming out as far as long-term use. Again, not enough evidence, but interesting thing, if you get asked by a client, it's worth having on your radar that there's some soft evidence that may be of benefit in long-term anxiety reduction and relaxation, I imagine.
Anna,
yeah.
What about evidence for long-term, like studied anti-anxiety meds?
The two that have been studied and concluded on are fluoxetine and amitriptyline. Yeah. And amitriptyline, first studies indicated that it decreased incidence of recurrence, and more recently there's no evidence that either of them decrease incidence of reobstruction long term. But again, that's a little bit surprising and counterintuitive given what we know about the causes of this disorder. But certainly the environment is by far the most effective change that we can make.
And what about, I know there's the probiotics, but I don't know if there's any evidence that they're helpful for prevention.
There's not any evidence, basically. Let's talk about cystitis. What time are we? Yeah. So say so we've got a cat, a 2-year-old cat who's presented in exactly the same way. It's a female cat this time. And we do our urinalysis and culture, as we talked about, and the culture comes back positive with an E. coli that's sensitive to absolutely everything. It's a first offender. The name, oh gosh, I don't know how to structure this question, sorry. What are you going to do? Are you going to put on some antibiotics and then you're going to move on with your life probably?
3 days of amoxicillin or
Good. That's what I was trying to get at. How long are you going to treat it for?
3 to 5 days, not more.
3 to 5 days, not more. Yeah, exactly. So we're sort of learning a lot from humans because they're ahead of us in everything, but urinary tract infections, because of those local immune protections that the bladder has in place, you need to get rid of most of the bacteria, not all of them, and the body will just do the rest. So 3 to 5 days is usually adequate for antimicrobial usage. And beyond that is just predisposing to more kind of dysbiosis and resistance development and not necessarily recurrence or anything, but it's just unnecessary.
Also, Anna, I really feel it's important to reculture them 4 to 5 days later.
Do you know
Make
what?
sure you have cleared it up.
Yes, in second offenders. So they've actually released guidelines on this now. So where they used to say uncomplicated UTI, they're now calling sporadic bacterial cystitis. So if there's less than 3 incidences of cystitis in a year,
they're just calling it sporadic bacterial cystitis, or less than 2 incidences in 6 months. So if they have 2 incidences in 6 months, you say, okay, well, this is now recurrent or relapsing or complicated UTI. But now if it's only infrequent and it's sporadic and kind of very acute onset, there's no urinary signs in between, they're calling that sporadic bacterial cystitis. And they're actually not recommending follow-up culture or intervention at all on those patients. Yeah, which is a bit surprising, particularly given we've shortened the antibiotic course. It would be nice to document that we've cleared it. But they say just because of the frequency and lack of severity of lack of risk, I guess, of this turning into a big problem, they're recommending no further testing. And then the other thing, I guess, with the theory of a shorter antibiotic course, you might still have some bacteria, but we're relying on those local immune factors to be able to clear it. So if the dogs aren't symptomatic, we shouldn't be treating it anyway. So we almost don't want to know about it. Was somebody else going to say something?
There is an antibiogram study done, or local antibiogram done, which says that with uncomplicated UTIs, like with cocci, treat with amoxicillin, and with bacilli, TMS.
There's a local one done, is there? Yeah, right. Okay. Yeah. Makes sense.
I haven't actually used it yet, but I'm thinking of doing that.
Yeah. I tend to use just amoxicillin for everything because it's not got great spectrum for gram negatives, but it's got such a low complication rate, whereas TMS does just sometimes upset some dogs. And cats, I don't know if you've ever tried to give TMS to a cat, but that froth at the mouth and it's all very dramatic. So amoxicillin gets to such high concentrations in the bladder, in the urine, that it's going to knock off most bacteria, even if it's not within its kind of very sensitive spectrum. So most of the Enterobacteriaceae, which are the common causes, are going to be more sensitive to TMS on the culture plate, but not at the concentration that TMS gets to in the bladder. The amoxicillin is so much more concentrated that it's going to take care of it. So that's my usual go-to, but I have to say that the latest review, particularly with pyelonephritis, did change my prescribing behavior. So if there's suspicion of pyelonephritis, quite often we see just a little bit of an active sediment or a little bit of protein in the urine. The urine might culture negative, and often I'm doing the ultrasound and the animal's unwell and they've got a bit of a neutrophilia, and I'm going, oh, the kidney doesn't look 100% normal, but it's not slam dunk pyelonephritis. The recommendation, if there's suspicion of pyelonephritis, is enrofloxacin. So straight to the big guns.
If there's rods or if there's cocci?
Even if you don't identify any bacteria.
Right.
They don't recommend amoxicillin or clav or TMS for pyelonephritis. They just go straight for fluoroquinolone, Marbo in cats.
How long? For how long?
Until you get your culture.
Well,
the culture is already negative, so how would you?
Yeah, so often the culture is negative with pyelo, but they say 7 to 14 days, where traditionally I would have done 6 weeks. So they've definitely changed the recommendations quite significantly in this latest consensus statement.
Is there a dose change for Enro? I heard someone say recently that there's something published that 20 mg per kg for 3 days is equal to amoxiclav for 14 days. I don't know where this came from.
Oh, there's a study that compared 2 treatment groups, one that had clav for 14 days and one that had enrofloxacin at 20 mg per kg for 3 days. And the reinfection rate and resolution rate were the same. So they're essentially just saying they're just as effective. What I would have liked to see in that study is clav for 3 days versus clav for 14 days to see whether it was just as effective, because that's now what they're advising that we do. So I'm not sure what the conclusion from that study is, but we know that Enro was not a responsible antimicrobial choice, given we were dealing with bacterial cystitis, not pyelonephritis. And we're probably going to be prescribing clav or amoxicillin. And clav is fine. Like, a lot of clinics don't have amoxicillin in stock. If you don't have it, just use clav. It's completely fine. The clavulanate component doesn't concentrate in the urine, so you don't get the benefits of having clav in there. So it's just a really expensive amoxicillin. But if it's completely fine.
Not according to the ASTAG guidelines, like clav is actually a medium, like the ASTAG guidelines. Clav is a medium antimicrobial.
Yeah.
So there's different for pyelonephritis and bacterial cystitis consensus statement. There's not a consensus with the with the responsible use of antimicrobial guidelines. So in the urinary tract one, it says clav is completely fine. So yeah, it says if amoxicillin is not available, just use clav.
I would say that every clinic should just be stocking amoxicillin, though. There's no excuse not to stock amoxicillin.
Yeah. I definitely agree. It's so cheap.
But just the main pain in the ass is that it tastes terrible. If Imbova won't compound it because it's available, and we just need it to taste better for cats.
That would be nice. Okay, so what if we've got a 2-year-old male entire dog who's presented with hematuria and stranguria and dysuria. And we do our culture and it's positive for E. coli. Is that sporadic bacterial cystitis or uncomplicated UTI?
It's a bit sus because he's male.
Yeah. So why do we treat entire males differently to other dogs?
He might have prostatitis. Yeah. He could have a very tight urethra and
so I'm suspicious of prostatic involvement in an entire male dog if I see a UTI present. These guidelines say to treat them the same as you would for sporadic bacterial cystitis, but do more follow-up in this patient. So again, unless the main follow-up you're doing is advising the client to monitor for recurrence of signs, because if you've done 3 days of antibiotics and this dog's got prostatitis, it's going to be back at the end of the week. And that's going to be your diagnostic test. And if it's not febrile, doesn't have a neutrophilia, and isn't otherwise unwell, it's not got life-threatening prostatitis and sepsis, and you can just do the 3 days, treat it as an uncomplicated UTI. And then if it relapses or comes back, then you treat it as complicated UTI and prostatitis. How do we treat prostatitis?
Enrofloxacin.
Yeah, that's the first line. TMS is not a bad choice either. I'm definitely going to send you the guidelines paper because they've got a really nice just list of antibiotics, like do not use, not recommended for this, recommended for this kind of, and doses and everything. It's really good. I'll just make a note to do that because I forget things like that. Okay, so prostatitis we're going to treat for 7 to 14 days, but the other thing I'd like to add in is an ultrasound in these patients, because if there's an abscess in the prostate, we're going to have to do something about that. Oral antibiotics aren't going to cut it. What are we going to do about that?
Would you do surgical or, depends how confident you are to aspirate and pull out the pus?
All the pus. You don't want to leave any in there.
I would also want to desex this dog. I would very strongly advise to desex this dog.
Absolutely recommended for sure. Yeah. Sometimes with prostatitis, they present quite unwell and they're not candidates for surgery at that time. What is another option? The surgical desexing.
The implant.
Yeah, chemical castration. Superlorin. Yeah. That just gets you can get an implant that lasts 3 months, get rid of the prostatitis, castrate them sometime in that 3 months, and it just buys you time. Josh's cat's the best. Okay, what about if we've got a young female dog who has been in 5 times with clinical signs of a UTI in the last 6 months? It's every time we've looked at it, it's E. coli It looks like the same organism with the same sensitivity pattern. Every time we treat with antibiotics, the signs go away and then the signs come back again. How are we going to approach that differently from our uncomplicated UTI?
Firstly, I think you should culture mid to see if you're resolving, and then after stopping the antimicrobial 7 to 10 days culture again. And then also look for comorbidities. There must be something driving this.
Good. Yeah, absolutely. What might they be?
What was the signalment? I didn't listen to that.
A 2-year-old female dog with 5 presentations of lower urinary tract signs in 6 months.
Ectopic something? Ectopic?
Yeah.
Urinary tract disease.
Yeah.
Persistent urachal remnant?
Yes. Good. Yeah.
Be worried about the vulva, appearance of the vulva. Is it very small?
Absolutely.
Yeah.
With the vaginitis.
Be hunting for a nidus of infection somewhere for sure.
Yeah, absolutely. And I think that's the key here. We've got the same organism every time. That organism is probably still in the urinary tract. It's coming back into the bladder from somewhere. So it's unlikely to be a reinfection, because we usually see within 5 cultures, we'd see like one being a staph or one being a proteus or something like that, not E. coli every time with the same sensitivity pattern. So we've got something in here where there's like a little abscess or a pocket of infection that just is reinfecting. There's one thing we haven't mentioned, is probably actually the most common cause of reinfection like this.
Well, neoplasia, but unlikely in such a young dog.
Yeah, and uncommon to present with infection as the primary source. Stranguria for sure, but you wouldn't be culturing E. coli each time, I wouldn't think.
Definitely urolith, you got to exclude.
Good, yeah. So in a urolith, the bacteria just gets caked in the stone, and as you know, if it's a struvite, you treat it, a little bit of the stone dissolves and all the bacteria come back out from the layers, the internal layers of the stone, and then you stop your antibiotics and there's still the stone there and the bacteria just reinfect the urine. So urolith for sure. Persistent urachus, Jeff mentioned that. Does everybody know what that is? Yeah. Good. Excellent. I know what that is, and I look for it on ultrasound, and I'm yet to see one. I do a lot of ultrasounds. They're not very common.
Maybe foreign body?
Foreign body, great. On the interventional endoscopy forum, there was a dog with a grass seed in its bladder. It's pretty cool. Yeah.
Can I tell you a cool story? This happened, I think, 1.5 months ago. We had a referral. This was a 2-year-old. Can't remember this. I think it was a pug type thing. Not pug, sorry, Frenchie.
Yeah.
Recurrent UTIs, 2 years going on, referred to us. We did a cystoscopy. There was a carrot in the vagina somewhere.
A carrot?
Yes.
Oh my God.
Maybe there was.
It was
kids messed up.
just for 2 years.
Oh my God. Far out.
Oh my God.
Yep.
Hopefully that was a 3-year-old that intervened there.
Far out.
I
don't even want to speculate.
Yep.
Yeah, so you can never rule out foreign body. There you go. And the other one that's definitely a consideration, given the shift in breeds that we're seeing, is urethra seals. French bulldogs are overrepresented, and they just get this like little pocket, like almost like a diverticulum off the side of their ureter, and it's often really distal. It's often right next to the bladder. It's almost like as the ureter is inserting into the bladder, and it's really hard to identify on ultrasonographically, often only identified on contrast studies. And if you've got chronic reinfection of the bladder, and you've like ruled out everything else ultrasonographically, that's the thing that I'd be most suspicious of. And then the other thing that was kind of a bit of a revelation for me, because I've had this, obviously a dog that belongs to a nurse, very complicated, always E. coli, always culture positive, intermittently symptomatic, and this dog just lives with E. coli in its bladder. Apparently E. coli that has invaded the tissue amoxiclav is a terrible choice for that. So we're culturing this amoxiclav sensitive E. coli from the urine, and I'm like, antimicrobial sensitivity, responsibility where I'm prescribing Clav. I'm going to keep prescribing Clav when this dog becomes symptomatic. But actually, if this dog's got E. coli in its bladder wall, the Clav's not going to work based on these guidelines. So now I'm really excited that I've got permission to try a different drug.
But is it like a different E. coli? You know how with the boxers, with the colitis, they have that adherent, whatever that is. Is it like similar?
It's probably just bad luck. Like this dog probably had an underlying factor, which meant that the E. coli could really kind of grab hold and get in. But invasive E. coli are part of the flora. And if just happens to be one of those that gets up in there, that's sort of, hopefully that'll be the answer for this dog. Anyway, we better wrap up. I'll just see if my dog's around.
Hello.
I'm going to introduce your cat to the dog, Josh.
Yeah, he was like, he gets really protective of things. He was with my mouse, and I couldn't go near it because he would attack me.
You thought it was your.
Yeah, he was playing with the computer mouse, and whenever I tried to reach for it to unmute, he would start attacking me.
This is Skippy.
Oh, there he is.
Oh, cute.
Oh,
So cute.
What's his name?
Skippy.
Oh,
Look.
pretty baby.
Anyway, so this is what's keeping me up at night. Oh no. Oh.
it looks like a troublemaker.
Yeah.
What breed is he, Anna?
Kelpie Whippet cross. Same as me.
Oh, wow.
Same. Look, his little whippet face.
I know.
Oh, he's very cute.
Thank you.
Thank you for bringing him out.
All right. See you guys.
Have a good day.
Thank
Thank
Good
you.
everyone.
See you in a
Thanks
fortnight.
so much.
Thanks, Anna.
Bye.
Bye.